All right, good afternoon. It is 1:21 and we will call the meeting to order. Thanks everyone for being here. Due to the intrepid Mike Shaw, I don't have to waste time reading off 1,000 names, 80% of which aren't here. So we have the attendance on the phone and we do have a quorum. Thank you. Before we dive into today's business, the minutes from January's meeting were sent out with the agenda. Hopefully people had a chance to review those for errors or omissions. I would entertain a motion for either an amendment if there's anything missing or a motion to accept the minutes. Motion to accept. Is there a second? Like pulling teeth.
I will second.
Thank you. Any opposition to accepting the minutes? Hearing none, the motion carries. The minutes are accepted. Thank you.
Dr. O'Brien, I've got a couple of people saying they're not able to get in. Could you just see if there's anybody in the waiting room?
Yep.
Thank you.
Just wait a second.
Hey, it's Mark Kenyon. The link didn't work, but if you type in the numbers to Zoom, you can get in easily.
We're gonna copy and paste. I'm told works. Works for it.
There is no waiting room.
Okay. Correspondence log was included with the minutes and so we'll jump right in, starting off with CMAC, Dr. Walter.
So the February CMAC Semsco was canceled due to weather emergency downstate, so there was no meeting. So the next meeting is going to be not until May 12th and 13th. All the things on the agenda, such as the collaborative protocol updates that were discussed in the previous meeting, but were supposed to be approved, have gotten pushed to the next meeting. So if there's no report other than that.
Great. Thank you. Chairman's report. Really, I just have one acknowledgement and one announcement. Dr. Josette Teuscher, after many years of dedicated service to the REMAC, has stepped down as the Wyoming Erie, one of the Wyoming Erie at-large representatives to the REMAC. We thank her for her years of service, advice, and guidance. She's still practicing in the area and is still available for us to bother with questions, and I will make sure I do that. So thank you, Dr. Teuscher. In her place, the Wyoming Erie Regional EMS Council elected Dr. Johanna Innes. So she is now the second at-large representative from the Wyoming Erie region. So welcome officially, Dr. Innes, to the REMAC. I'm not sure you know what you've got yourself into. There. That's all I have. I'm told there is no report from the Trauma Advisory Committee today. The next meeting is scheduled for April. So we will look forward to an update at that time. So moving right into program agency reports, we'll get started with STEMS and Alicia.
Hi, everyone. My report was included with the agenda. A couple things to note. We're having a certified instructor update course in June, and that course will be held hybrid. So you can either come to our office in Olean or attend online for credit, and that's for CICs and CLIs for their required CIU that they need for their recertification. Additionally, we're having the Southern Tier EMTB Academy again this summer, and our application for that is currently open. We're happy to report the paramedic program is coming to an end here in the next couple weeks. So after that, we'll hopefully have some new paramedics out in the field. And then just a reminder that the Part 800 changes, some of them are going into effect in April, with the rest going into effect in October. Thank you.
Thanks, Alicia. UVMD, Mr. Shaw.
I also included a report that went out by the secretary. We're continuing to work on data, analyzing data. Some of our daily reports that were going out, we're switching those over to weekly reports. But we're looking at transfer of care times. We're looking at ambulance turnaround time, so on and so forth. We're also comparing what we have in the Western Bridge compared to what's in New York State, and identifying some import-export failures and such. Working with those agencies, trying to get all that cleared up. So we conducted a second REMAC preceptor skills workshop that was done in Wyoming County on February 21st. We've had So very positive feedback with these. And we're looking to schedule a few more, at least one more in Erie County for now. And then, one or two in the Big Lakes region. With that said, we've also went through our list of current preceptors that was posted on the WREMAC website. And started cleaning that up, and I think it's pretty much cleaned up. Taking out, providers that, EMS providers, preceptors that are no longer certified, or maybe they left the area. Just try to get that cleaned up so we can get a fresh list over to STEM, so they can repost that on the site. We've been working hard on recruitment retention as well. We did push surveys out, both in the Big Lakes region and the Wyoming area region. One survey specific to agency leadership, answering on behalf of the agency, and then the other one specific to EMS providers. So big push on that to get EMS providers and leadership to fill those out, so we can start working towards getting a plan together and coming up with key points and creating action on recruitment retention. That's pretty much all I have. Everything else has been pretty much talked about by STEMs or faculty members.
Thank you. Subcommittee reports, Dr. Walters, with the cancellation of CMAC, is there anything from collaborative group?
No, just like I mentioned, the updates will be approved at the May meeting. They were scheduled to take effect on July 1st. As far as I know, that's still the plan. I don't know if it'll get pushed back at all because of the delay in the meetings, but we'll find out today. Once those get approved, then we will send out the change log to everybody of kind of outline of what was changed and what protocol and that, so you don't have to read through 200 pages to find what the changes are. But that will be coming out soon.
Thank you. I know Dr. Tanaka's on the phone call. I don't know about Dr. Borton, but anything from QI?
No updates from QI.
Thank you. I spoke with Dr. Plunka, who couldn't make it today. There's no report for the policy review ad hoc committee, which brings us to the stroke committee.
Our next meeting is March 31st at 6 p.m. This will be a virtual only. We did put a blitz out to the area asking for additional people to be on the committee. Thank you to BMD for putting that out for us. We did get an additional 20 providers from throughout Western New York to join the committee. So if anybody else is still interested, they can reach out to me and we'll be happy to take additional.
Great, thank you. Interfacility Transport Committee. Todd? We have some items that may generate some spirited discussion, but so far we're on target for the fastest 3-minute meeting ever. All right, there being no further reports, we'll move into old business. I'd like to start with number 3 there, the discussion on revising the on-scene licensed healthcare professionals policy.
So this came up at the January meeting, and I think it's a couple weeks prior to that. That we were discussing some clarification on 2004-2 in terms of a couple of points that we were trying to clarify. Brian brought up the question of kind of identification of providers on scene, especially at such things as MCIs, as we can try to standardize that or make that a little more I guess immediately obvious when there's a scene like that where there's so much chaos trying to figure out who's a provider or not. Cards would work at MCI, but one option. I don't know if you had anything else on that particular part of it. Any other ideas? I hope that'd be great.
Some of the agencies that I'm affiliated with have chosen to purchase, like a reflective vest that says physician on it, or whatever your profession is. The thinking being it's high vis, easily recognizable, and probably something you should be wearing at the scene of anything like the throughway accident or anything like that. Obviously, there's cost, although vests like that are not cost prohibitive. I know there was a time in the remote past prior to my time here, when WREMAC issued cards. I don't see how that's really any different than, the New York State, health professions ID card you can request if you have a professional license. And again, I sort of feel like the idea of having to whip out your tiny little card, every time you walk up to somebody new at the scene of an accident or an MCI is I don't know, just seems not the kind of thing we need to worry about. I think that's something better like a, you know, some sort of high vis vest or a shirt or a jacket or something that has big letters on it that identifies you as somebody that you know, that you are. Any other thoughts? Where's the gallery?
I think there's be wary of DOT compliance if the MCI is on a roadway.
Yep.
Square inches of high vis of reflective material required for all responders.
I believe
that's something that's a uniform appearance.
I believe the standard is 3 inches. I know there's enough. So, yeah, I think that makes the most sense. I don't know that we certainly don't have any standing to require people to do that. In that they're not usually responding on behalf of the REMAC, so we don't have any teeth there, but I think we can make a strong recommendation in compliance with DOT regulations that, you know, for safety and ease of identification and smoothness of patient care and avoidance of errors or taking orders from somebody inappropriate or not taking orders from someone that is appropriate. We can make a recommendation that the REMAC feels, however we want to word that the, you know, high vis, the ANSI number, whatever, high vis vest with letters at least this big that say, you know, your title. And I think we should keep it simple, right? Like physician would be good. If we want, you know, if agencies have nurses that work with them and they want to get ones that say, you know, registered nurse or nurse, that sounds great too. You know, everybody on the scene of any kind of roadway should be wearing a reflective vest daytime or nighttime. I'm guilty of not doing that. I know a lot of the people in this room are also guilty of not doing that. It is what it is. We jump into our job role and don't always think to go digging for the vests. But I think that would be a fairly inexpensive, rapid way to identify and also provide a little protection for those of us that are standing out there doing the work on the roadway where things get dangerous and unpredictable.
So was the intent of this discussion to identify the physician or to verify the physician?
I think the intent of the discussion, so it's come up in a couple of different ways, one of which is the current policy 2004-2 talks about a physician who's on scene. And I think what it contemplates is a random occurrence, right? Yep. Physicians at a restaurant, somebody chokes. If the physician wants to get involved in care under that policy, it's not offering medical direction to the EMS crew. It's providing and accompanying the patient through transport.
Agreed.
We have a lot of circumstances now where EMS medical directors and EMS physicians are responding to calls, which is distinct from happens to encounter a patient. And in that response, there's no guidance on how medical directions handled, how it's reported, what we do in terms of documentation. And absent that guidance, you know, we look at the policy in terms of other state policies where medical control lines are supposed to be reported for QI liability purposes. That obviously doesn't happen one-on-one unless somebody's wearing a body cam, which is usually not the EMS crew or the physician.
Right.
So we have to try and get law enforcement to give us body cam footage for that.
Right.
Plenty of challenges there. So I think looking for REMAC guidance outside of the casual encounter, right, where it is a responding physician. So somebody who is responding to a call through whatever mechanism, and then looking at those mechanisms, whether there's centralized dispatch, which I really think there should be. It should be a organized program that is resulting in dispatch of an asset that is reliable and repeatable, as opposed to
trackable and accountable,
as opposed to randomized occurrence.
Yep.
And then what does the documentation of the interaction look like? Because I think it would be silly to say an EMS physician who would otherwise be giving orders on the phone could give those orders. That's perfectly permissible, but because they happen to be there in person, they can't give those orders, now have to accompany the patient. Right? That seems incongruous. Probably should have more exploration direction.
I think that would probably be best served, since they are two different phenomena, by a new policy, you know, talking about healthcare professional scene response or something that denotes that this is actually a specific person responding to the scene based on a request, and then addressing those things therein. In which case I would recommend that we refer this to the policy review committee to draft a policy for us to discuss and vote on as a group. I don't know that the first time we see it, it would be ready to do that, but you know, there's certainly questions we have to answer of, you know, we can say in a policy that ideally this would be centralized dispatch. It would be even more optimal if we could hammer that out at the time that we're actually passing such a policy. I know, it's been a while since our friends at MERS came and talked to us about, 898 MERS and its potential. I know, there are a couple agencies that have or are developing, smaller physician response tactics, we'll say for now. And I think we need to imagine or conceptualize the way to try to centralize those, at least from an MCI perspective. So that way there's one number or one entity we're contacting to request physician help when we're working with an agency that doesn't necessarily have an embedded physician that they can just call directly.
So I think, I look at it, I think, in like 3 different levels, right? There's because the policy initially was to handle the physician of whatever specialty who just happened to be on scene and wanted to give orders, right? Like the primary care physician who happens to be there, who doesn't know EMS protocols or, and really can't give on-scene medical control, right? And those were the ones that were then, you were supposed to accompany, if you were going to get involved in the care, accompany the patient to the hospital. And then I think the next level, and maybe we're going to parse this out in the policy, and that is you have a WREMAC authorized ER physician who gives med control orders on a regular basis when they're working in the ER, who happens to be driving by the scene and is on scene, and by all rights should probably be able to give orders to the crew, just like they would if you called for medical direction, right? And then the last part of that would be an organized physician response through whatever entity that is, through an agency, through county, through however it is. And I think there's 3 different kind of nuances there, right? I would say if you are actually an organized physician response team or entity, then you probably have something that identifies you, like an ID, a vehicle, a badge, something like that, right? But I think those are 3 different levels of what you would expect and what we would allow them to do, or how they would be expected to account and record things. Does that make sense? Or disagree?
No. Other thoughts? It might be that, it might be an optimal course to rather revise policy 2004-2 to just include those 3 separate categories.
That's what I'm saying.
But I think it would be, I think this is specific to non-medical control positions. I think having one that's specific to medical control positions would be better. Because then you're trying to put everything in one. I think it's better to keep this one as just
Separate.
random doc who's on scene. How do you deal with that versus on-scene medical control by a WREMAC position? Just because I feel it's a different topic, basically. You know what I mean? Trying to shoehorn it into this existing random doc on scene versus specifically on-scene medical control might be as its own document better. Because I'm gonna have to really mess with this. Because there's not really too much you have to add to random doc on scene, whereas we really have to reinvent a whole new policy for on-scene medical control if we're talking about all these nuances. Because the existing one really probably doesn't need too much if we're just talking about a person on scene who's a provider. Unless anybody thinks we have to change anything, the verbiage on the previous one. Because I don't think that carves out on-scene medical control from a WREMAC position. I think that's a different topic.
I think if you do 2 different policies, I think as long as you account for kind of those 3 different categories, I personally don't see a difference. You do it as 1 policy or 2, we do 2, I think that makes sense.
I would be happy to draft a policy on this. And then I can refer to the policy review committee, or we can discuss it as well.
Would you work with Martha on the draft? And then
Sure.
if she wants to have her, maybe look at it, she can,
Sure.
but I don't know that we, at least for the skeleton of it, I think just 2 of you.
Yeah.
A good start.
Sure.
Cool. And then anybody else that wants to join?
I think I'll fall through Dr. Walters to.
I like that.
And that's well.
I like it.
No, sorry.
I rejected that. Oh, do we?
Yes.
All right, working backwards then, discussion regarding the use of spit hoods during EMS transport, Dr. McNamara.
So this did come up as a couple of questions that we started the conversation last time. The existing restraint policy does not actually have any guidance regarding that specific device. And there was some discussion from Dr. Greta about making it clear that this was not a protection against biologic, pathogens. This was specifically just for literal, contamination by bodily fluids. So the question was, does this need to be a revision of the existing restraint policy to specifically address spit hoods and the REMAX policy on them? Or should this be a new statement from the REMAC about, our group as a body feelings on whether these are things that should be used, should not be used, guidance around their use. From what I can find on a cursory, review of the existing literature, there's very little recommendation for their use because of both the limitations and actually preventing any exposure to anything that might be in said bodily secretions, or as a just protection from splash, for lack of a better term. So it would seem that the existing literature would not support their use, but again, just as a purpose of consensus, thought it was reasonable to ask if, there's on the other side who feels they are reasonable, if there are circumstances where use is warranted, and then if so, what the guidelines would be for their use.
Open discussion. I think it's important to remember that especially with a limited amount of evidence, right? Like lack of evidence of benefit does not mean evidence of harm. And it doesn't, it could just be so far neutral. It could be that the data just crosses zero and we can't really say one way or the other. There's just not much out there yet. So what do people think? How many agencies in here are using spit hoods in the room? Anybody?
The questions that were raised that I got were primarily from when they were placed by law enforcement.
Yeah.
Then EMS is contacted for transport.
Yeah.
And the question was maintain them in place, remove them, which, certainly could be an agency level decision, but I think these are kind of broader questions that are not reasonable to ask as a larger body. I think regardless of whether we endorse their use or not, comments about, PPE used by the providers is probably a more reasonable push, as well as, chemical restraint for the use of violent patients as an alternative to these. But again, just as a broader question of whether or not the REMAC wants to endorse their use, push against, remain neutral, just figure it's a reasonable thing to comment on.
So go ahead.
Yeah, this is Brian Clemency. I support their use. I think that when crews are appropriately trained to use them and monitor the patient, they serve to de-escalate the scene. I think there's a lot of big emotions from all parties involved when a patient starts spitting. And while I understand they are not perfect devices, I think when used appropriately and patient monitored appropriately, they are an important part of kind of de-escalating all parties involved in a call.
Other thoughts?
So I don't disagree with Dr. Clemency's saying. I think there's two other things to consider. One is there have been some discussions nationally, and I forget if it's EMS1 or GEMS, like looking at spit hood use across the country and some of these bad outcomes, which there are probably bad outcomes from a multitude of factors, which could be patient assessment, patient monitoring, medications that were given, all those things. But insinuation that spit hoods are linked to bad outcomes or deaths, things like that. And so that is one of the political things to be aware of, that I think we just have to take into consideration. I don't disagree with their value, like Dr. Clemency is saying, and the other side of that is, and I know I'm speaking on both sides of my mouth, because I'm not saying for or against them, I'm just saying the discussion points we should be having. There was also an article a few years ago in the American Journal of Emergency Medicine that looked at spit hood use and physiologic parameters and breathing in healthy subjects, granted, which may be different than some of the patients we're putting these on in your agitated delirium patients and such. But that showed there was no substantial physiologic effect, again, in normal healthy subjects. So just for support of data that there may not be harm that we're causing by placing these on, there is some data to support that. I guess the question is it something that we want to take a stance on the REMAC? Do we need some support for or against, or are people looking for guidance, or is this something that, what are we looking to accomplish?
Well, I think, if there's some heterogeneity among the opinions, then obviously you could make it an agency level decision, or, make it more of a decision at the patient care level, like you're on scene, the group makes the decision, but I guess the question is there a need to have something larger in terms of an opinion or not?
So I think this comes down to a lot of discussions that we end up having. So one of the issues that is equipped and trained is rampant in the protocols. I would think there has to be training specific to this stressing, monitoring of airway and patient status. A lot of the media scrutinies come down to negative outcomes. Most of those negative outcomes are probably not a result of the spittle. They're a result of not monitoring the patient who becomes unresponsive or has another issue. In terms of couching this, do we couch it as PPE issue, or do we couch it in a restraint protocol? It goes both ways across some of the literature that's out there, some of the discussions. I haven't seen anybody who's taken a strong position on this one way or the other. But I think anything we do has to come with strong guidance. And maybe the REMAC position is if the agency chooses to adopt this, it has to include training and a policy statement from the agency medical director. And maybe guidance from the REMAC on whether this is PPE or whether it is considered part of the restraining procedure. Just concerned that the direction this is going from some media, with the caveat that, media is media, is the same sort of criminalization that we see with chemical restraint is going to start to filter into some of these other things that we're dehumanizing patients. It's certainly not the case. And managing escalation on any scene, like Dr. Clemens was talking about, is critical in what this brings to that scene. But the idea of placing effectively a bag over somebody's head is not a great optic, and it requires a lot of explanation if media does get involved in that. So starting with specific policies.
I agree with that, and insofar as, we're talking about justifying it in terms of it's a means of de-escalation. While it does have some benefits in terms of PPE for reducing flying spit particles, I think I sort of worry that the optics would be worse if it, could be perceived as we're trying to hide it behind PPE when there are other PPE methods that we could and probably should be using in these cases anyway. I wonder if this, again, in terms of to show our seriousness in terms of how we monitor it, if we treat this as part of a restraint protocol, and thus, like every other form of restraint, where we already highlight the importance of careful consideration, careful application, and close monitoring afterwards, might ease the appearance of putting a bag over someone's head. Is if we look, this is part of our restraint policy, it is monitored, we have training for this. And I agree with the idea that if an agency wants to do it, I don't feel the need to notify the REMAC in terms of the same notifications of intent or anything, but I could have my mind changed about that. But the agency medical director needs to review these. There needs to be training, there needs to be a policy statement in the agency. I agree with all of that. I don't feel strongly about where we sort of house it, but I do think there should be at least a REMAC opinion on it, saying the aforementioned things. What other people think?
I think along with that, reiterating patient positioning, right? Nobody should wind up prone.
We don't prone.
Especially, constant monitoring airway.
Yeah.
Mental status. Is there a time limit for application? Like how long are you going to leave somebody in a spittle? And then ultimately, I think there should be some guidance either in that policy or from this body on documentation. So we're clearly documenting indicators for applying spittle, but also the rationale or reasoning that it's a protective measure or a de-escalation measure.
I agree with that. Do you want to draft that with Marta as well? Since you're already doing one? Perfect. Thank you. All right, back to number one, discussion regarding mental health transport correspondence.
I'm gonna throw one in there before that, just to add something more to the plate, just because I feel like that one might take a little more time.
That's new business, Dan.
I know. Well, technically it's old business.
Oh, okay.
Discuss with Karen.
Go for it.
So last time we were discussing the equipment list and REMAC formulary, and there was a general consensus that instead of doing it every year or every couple of years to try and mirror everything, that it would be reasonable to mirror the collaborative protocol formulary and equipment list in terms of standard required items. WREMAC essentially does that currently. I reached out to Jeremy. The only difference they have is for any optional medications that are in the collaboratives as optional, they have a regional medical director that approves it. We don't necessarily have that with our REMAC. The question would be for that carve out for optional medications. Either we could do an approval on a case-by-case basis like we do for other optional skills. Or it could be left to the agency medical director approval as training equipment, basically, to Brian's earlier point. I think either way would be easier than having a separate list of equipment and medications from the collaborative list that we already have a tough time updating every, year or so. So I think that would make things easier. It also can allow for agencies to, other than the minimum established by the collaboratives, carry more if they feel it's necessary, rather than us making that judgment for everybody in the region. So
Completely agree.
okay, we'll draft that. Yes, so that was that one. I did, sorry about that extra one. In the mental health transport correspondence, I was just bringing that back up just because during the last meeting, we did discuss it. And there was a revision to that. I just wanted to, number one, ask if there was any update or any further revisions of that particular memo. There were just a lot of questions about it, so that's why I felt it reasonable to bring up.
Bring on the questions. There has been no
Okay.
revision since the first revision.
Okay. So there were just a fair amount of questions that I don't know if anyone else had received. I had received from my EMS agencies as well as law enforcement with some specific questions regarding that documentation that we were just trying to get clarification on, because there was a fair amount of, I don't want to say confusion because that's the wrong word, but a lot of different questions that came up. So specifically for the 2209s, we just want to make sure that it's clear that, other than closest facility, just most appropriate facility. If it's a patient that's being sent to a place that's got, 2 nurses and 1 doc, if there's a potential they could become violent, not just are they violent, but later on, perhaps considering that in terms of destination. Not saying they all have to go to ECMC, but perhaps a slightly larger facility with more staff would be reasonable, rather than simply saying closest, because closest might be somewhere with 3 people. Was the first question.
Yeah, the answer is always the closest appropriate facility.
Sure.
In cases of 2209 and similar cases without the papers, it certainly seems that the closest appropriate facility winds up being ECMC an awful lot of the time.
Sure.
And I certainly understand that we have a hospital police force that other hospitals don't enjoy. However, other hospitals often don't have zero security, but there are certainly some that do. And some of the ones that do have less than effective security. But, the argument of, or the assertion of like, well, what if, how do you decide who may become violent? If they're not violent now and they haven't been violent throughout the call, I think asking anybody to predict, oh, this guy might get pissed off when he wakes up, or this guy, as soon as we drop him off, is going to get pissed off, isn't an assessment I think any of us can really make. And, there was a case, and again, there's case studies of every ridiculous thing, but just 2 weeks ago, there was a case where somebody was brought all the way to ECMC from somewhere far, doesn't matter, because they were fighting, right? Well, that was great, but they got ketamine on the scene, and by the time they showed up, they were asleep. So, kind of threats over, right? And that person probably could have gone to a medium-sized place closer than where they wound up. And, in the time where everybody's struggling with boarding and throughput and lack of beds upstairs and lack of staff because we're busy caring for boarders and whatnot, it overwhelming any one place with any, often prolonged stays because they have to metabolize or they get sedated or they got sedated outside the hospital, is not helping that problem anymore. So the spirit of that memo was to emphasize not like stop bringing everyone to CMC, but it was to emphasize that let's not pretend that everybody in this room hasn't heard or personally themselves brought a 2209 into a non-ECMC place and gotten yelled at for, oh, they're on papers. And so the point was to emphasize to you that section 2209 of the mental hygiene law does not specify a facility. It does not specify the capabilities of that facility beyond it is an Article 28 emergency department. So I'm certainly sensitive to the places where it's 1 doc or even 1 PA and a nurse, right? Absolutely, totally get it. That's what, closest appropriate facility is meant to account for. But this isn't, I'm not trying to put this on our EMS providers, right? There's a couple that instinctively go to ECMC because that's been the habit or that's been the culture, but part of the driving force behind this is as our law enforcement partners that are under the impression, or their old forms that they've had for 40 years still have ECMC as the place on the top of the form. That isn't what the mental hygiene law says. It's never what it said. And that was, something that is something we still have to deal with. So if there are suggestions on how to clarify or better word or expand or whatnot, the guidance in that memo, I would love to hear them so we can try to figure out a solution to this problem that has plagued us since they repealed prohibition.
You had, it's not the language of the memo, it's the addressee. How do we get this to law enforcement?
Yep. I'm working on how to do that, short of just mailing copies to every chief, because I think they get enough email or enough mail that they don't go through. But I would love suggestions on how to do that. I'm not, personally aware of, I know, like, for example, like Amherst Fire Chiefs have an Amherst Fire Chiefs meeting periodically. I don't know if police chiefs in the region do that or not. That might, if that such a meeting exists, that might be a venue to have a discussion, if somebody wanted to, if they would welcome someone to come talk on that side of things or ask questions of them on that side of things. I'll have to look into that. I'm not sure that happens. Sense. Any other thoughts on how we can synchronize our thinking with our law enforcement pals? All right, I'll keep digging. I mean, short of, there's certainly a couple agencies that by virtue of the size of their jurisdictions do this more often than, they put people on 2209 papers more often than others. So maybe I try to start with some of the bigger agencies, because reaching out to 3 or 4 chiefs is certainly going to be easier than trying to get it to every police chief of every place in the region. Any other?
Good place to start, because they also do continuing education for officers.
That's a good thought. I like that. It's good that I do have some contact there.
The only other question came up about the pediatric patients, and I had a couple of questions that came up from law enforcement about that. So their question was, if the patient is a pediatric patient and put on a status 941 or 945, and they're brought to Children's, which currently does not have a mental health designation. Their question was, whose responsibility is it then to make sure that that patient gets to a 939 facility?
So it depends, as every good answer does. If the agency chooses to stay with that patient, which I don't blame them for not doing, but if they do, then it's on them. But the reality is, once the hospital accepts that patient and says, we got it, and pediatric patients infrequently, the little ones infrequently need a cot at the bedside. In the end, then it would be up to that hospital to ensure that they're transferred afterwards, which is part of why transfer mechanisms exist. But Children's, bless their hearts, on occasion will have their psychiatry people clear them and discharge them from there. I don't want to. I'm certainly not an attorney and certainly not one for the state, but I don't know I don't believe that really meets the letter of 941. But I certainly believe it meets the spirit of it. I can't tell a hospital that that's okay, and I'm not in a position to tell the hospital they need to stop doing that either. Those conversations all happen between the transfer and emergency department and CPAP, like the ECM CED isn't part of those discussions at all. The only guidance, 939, like the only guidance that section gives is really before the encounter is over, right? Before the person's released back into the wild, they have to go to a 939 facility and see a psychiatrist. So, the intent behind the policy, I think was furthered by the correspondence, I think was fairly clear in that, we have a ton of kids that are coming to ECMC and because of our shortcoming where we can no longer admit children, other than trauma over 15 over, we're hamstrung when people come in with what seems to be growing list of things that require 24-hour observation. And so, it ends up being an additional strain on the system requiring a transfer and a second emergency department visit charged, and plus plus the observation admission there. So I don't have an easy answer to that. But I think that the short answer to the question you asked me is, since most police are going to drop the patients off and then leave, the response, the burden then falls on the facility to arrange a transfer. But, in that instance, I think it's not unreasonable because, the conversation between CPEP and the evaluating provider should be about the medical clearance, right? Like, they were brought in because I guess they were saying this, they're all sedated now, so they haven't said anything to us, but medically they're clear. Can we transfer them over? I faxed, all 70 labs that we had to do and our notes over there. And that I think is the most appropriate conversation to have before the transfer, but I'm also still struggling with agencies that put people on 941 papers and then just throw them in the ambulance and don't go with them, which the mental hygiene law clearly requires. So.
Sorry, can you back that up? You said the mental hygiene law requires law enforcement to accompany.
It requires them to ensure appropriate transportation, and since they are in the custody of the police officer, they're supposed to go with them. Because that's what they're doing. They're not putting them in the custody of the EMS. We don't have the authority to take anybody to custody. Right? We have the authority to act in someone's best interest when they have no capacity and can't refuse, et cetera, et cetera. That's not us taking them into custody. Right? So mental hygiene law 941 is a mental hygiene arrest. Right? You're not free to leave. You're coming with us. If we have to put you in handcuffs, we will do that. If we cuff you to the cot, we have to do that. In that case, obviously, they have to accompany you because somebody needs a key. But they are supposed to come with them. It's not specifically said in the statute, but in that they are taking them into their custody, they should accompany them.
There are several agencies within the WREMAC's jurisdiction that don't necessarily feel that way.
I'm aware of it.
And
I took 2 patients from one of them the other day.
Yeah, I actually brought that problem up to Director Greenberg when he was in the area, and he had the same thought that seemed to be they should be accompanying the patient, but again, that's not really explicitly written anywhere, unfortunately. So I think that causes some consternation amongst our providers, but I
get it.
I think it's completely reasonable, however, to firmly request that law enforcement accompany or at least follow behind in the case of 941, because that's the other side of this kind of topic that we're talking about, with bringing them to somewhere else. Like who takes it off? Well, I was approached by law enforcement that said, well, if I drop somebody off, they clear them and don't send them to CPEP, then I'm in trouble. And I would kind of use that same argument to you have to come with us then to go to the hospital. So I think it goes both ways, but that's where that generated from.
That makes sense. I think this would be another ideal topic if I can find out how I'm going to approach the agencies about 2209. Why not have the same discussion? Same law, different sections.
Yeah.
You have another issue there too with the hospitals, where hospitals want to say no cop, no patient, which is pretty obviously not the case under a tele.
Right.
Patients presented, qualifying exams required.
Right.
And this body does have the ability to communicate a lot of that information back to hospitals.
Yep.
Maybe at least stopping the hospital behavior of no cop, no patient. And
Yep.
then
That's fair.
going the other way.
Yeah, I mean, I think we need to also, I think we also need to provide some cover, some support to our law enforcement partners. So, no, that's not medically appropriate either, just to say that and suggest that. So I think there's a couple of important discussions that we need to have with our hospital agent, our hospital partners, but also certainly obviously our law enforcement partners as well. So I will work on making some notes there.
I don't think it's just local agencies. I think you have to start at either the state police and also who else do we meet with when they're out there in number criminal
DCJS.
starting there, because I don't think that the interpretation that we kind of have or see is taken across the whole state. So then it's the accountability aspect of who's actually going to hold them accountable if they don't do that, right? We don't, personally, I don't want our providers to get in a shouting match with the officer on scene, because we've seen those and those go very bad at times because they have to work together. So it's ultimately who's the accountable party that's going to hold law enforcement accountable to actually come to the team.
Yeah, it's a good idea. I'll listen to DCJS. I have some context there. So I'll reach out and get some guidance on how they would recommend approaching this, rather than, come out guns blazing first. I think a softer collaborative approach is gonna be much more successful than a, why do you keep doing this, whining approach or yelling approach. So I will start exploring kind of some of that, and I'll report back in the next meeting of what I've learned. And then I would like to have a discussion then before I actually schedule any kind of meeting with them. We can talk again as a group of the points, and our position as a committee, rather than me just dictating what I think our position in the committee is. So that way we can actually have some informed talking points and a unified voice.
While you're on that subject, there are changes to 941 of the mental hygiene law effective July 1, 2027. They are subtle language changes, but they are being misinterpreted by many law enforcement agencies to compel transport of 941 patients by ambulance. There are definitely limitations addressed in that language. Does require an evaluation by the local EMS provider as to capacity, and the threshold question is whether or not the patient has suffered harm or has a medical issue. That threshold question is being ignored. So some additional guidance there before July 1, 2027 might be helpful.
Thank you. No, it's an excellent idea. Other thoughts on this issue? And it's an interesting dichotomy in that 2209 isn't felt at most levels to have the same, like the police have to come with you. But I think in those circumstances, most of those circumstances, the patient lacks capacity, and we don't really need the papers, but they help out. Totally fine, love that. It does help in the hospital too, because then we get to blame it on the cops that we're not discharging you right away. But that boils down in a lot of those cases to capacity. There's certainly some of the fuzzy ones where the person's walking, talking, shouting, not even irrationally, they're just bad. But yes, they had some alcohol today, and we struggle with some of those when they come in, and they end up getting discharged very quickly a lot of the time. But that is an interesting difference between 41 and 2209. I imagine that it might be because the perceived risk to the person themselves is different, right? Like you're just intoxicated, you just got to cool off, as opposed to I'm worried you're going to kill yourself, kill somebody else. So the risk of harm to the patient, I think, might explain that difference, but it is nonetheless a distinct difference, because in both cases it's a detention, right? And so it's a detention at the behest of the police. So it's just an interesting difference, I've noticed. I wonder if that's why, but more academic discussion maybe.
I think there's also important to communicate, because there's subtle differences there too, where they might feel that they meet one criteria and perhaps there's another avenue. Maybe they're 2209, not 41, not 941. And we can discuss that, if the crews feel that way, engaging in, medical control, to have that conversation of maybe this person isn't suicidal, maybe they're just drunk, so maybe they just need some time, versus sending them all the way to ECMC to metabolize just to say that I was drunk and I feel good. There's that goes the other way too. So,
yeah, totally. We have struggled. We continue. I think everyone continues to struggle with the 941. It's really just a sad drunk person when they metabolize. It's absolutely reasonable. No behavioral health history. And all they said was like, God, I'm just kidding. I might as well just die. And it's because they got drunk at work or something. But like, it's not.
I think there's even further discussion of like trying to find the right resources at the right time within the community, because I don't think CPAP is the right answer for the vast majority of people that actually go to CPAP.
Yep. I completely agree, right? So, if anybody hasn't been to CPAP, which I hope is most of you, but if you're not familiar with that, they don't start new medication there. They don't titrate your medications there. This isn't a place that you're going to go get a couple Xanax to calm down for a week. Right, they are there to evaluate whether you need to be hospitalized against your will for stabilization and safety, and that's mostly it. Almost everything else, once they make that determination, and if it's no, it's an outpatient range. So there's definitely some public and EMS and police and even healthcare provider misperception about what happens there, and it's not to say that it isn't a critical resource, but it is definitely not the resource for everybody that finds themselves there. And then we're stuck, we at ECMC, we used to have a practice of like, they come in on 941, but they're really just hammered. We'll assess them when they're done metabolizing, and we would discharge them. And a number of years ago, we sort of recognized that isn't really what the statute says. They do need to see the psychiatrist. And so, you know, just with heavy hearts, we'll send these completely sober, completely, you know, not at risk patients to CPAP for, you know, if it's a busy day, 6 to 12 hours. If it's a fast day and they're normal, like they might be out quickly, but there's not a lot of fast days in it. All right, well, I appreciate everyone's discussion. This was actually really, really good. I wasn't sure what I was walking into because I was lazy and missed the last meeting. But I think this was really productive. Yes, sir.
Yesterday, I had this exact same meeting in Niagara Falls, and I showed them the minutes for this meeting, and they would like to be a part of it, doing the exact same problems up there. Obviously, I just started there, but those folks would be willing to be involved. Vision or whatever, we have a committee that works on that up there. We have the same problems going across the county.
I would love it. And I say this with zero snark, although it may sound snarky. They have a representative of the REMAC. I would love them to come. And they're not alone. I mean it with no snark. I was at the end of the meeting, I'm gonna ask Karen if we could reach out to all of the EDs whose representatives haven't been here in 3 years to appoint new representatives.
I assure you going forward, they will be.
That's great. I welcome, the more voices, the better. The more, I've never enjoyed making decisions on behalf of, Niagara County facilities when there's no Niagara County representatives here. So please, that's excellent. Thanks, Rob.
Perfect. Thank you.
Anything else on this topic? Any other old business that we didn't think of, like Dr. McEnroe thought one?
Base station first.
Oh.
Meeting. So
Yeah.
I ask about it, then you forget until I ask at the next meeting.
I assure you I don't forget, but I don't get to it. So either way, can you put it on for next meeting is all business? Because it's like 10 years old. Thank you. I really just need to figure out how to deliver. I really just need to figure out how to put it on, like how I want to put it online and how we handle the verification that it's done. And I imagine it's just going to wind up being a signed attestation or an email or email sucks, but something just in the end, no one can sit there and make sure that you watched it, right? And I want everyone to do that. I would love to do in-person courses. One of the other alternatives I'm considering is, sort of like we have REMAC preceptors. Maybe we just authorize somebody at all facilities to do the base station training course for their facility. And then the facility can sign off. That's probably the best division of labor, while still maintaining some sort of like, there was somebody in a room who heard the words. What?
Doc, you can put that on our LMS system.
Yes. So yeah, but yes, next meeting, we will make a decision on how to do it. And then by the fall meeting, we'll have something done. Is that fair? Thank you. Just don't say bylaws. Base station course is fair. Predates bylaws. Any other old business? Old business. They are overdue by 6 years. All right, hearing no other old business that was omitted, and we'll move on to new business. Best self behavioral health. So, there is a springboard to the alternate destination approval that was given a number of years ago by the state. We have not really had a lot of alternate destinations wish to sign up, right? The initial, the initial intent, I don't want to say intent, but one of the envisioned uses of that on the regional level was, if somebody wants a ride to an urgent care center, if there's an agreement with that, we could do that, right? Low acuity complaints, dental pains, whatever, you can go to an urgent care and get seen, rather than, clogging up an emergency department. We were really hoping to try to push that out, when COVID hit us. But the urgent cares were just as overwhelmed as we were with the same, 6-foot restrictions early on that we were. So no one was able to sign up and make any commitment at that time. But and so it stagnated for a while on, at least in our region, there was no other real interest in it. But Best Self would like to and has submitted a proposal for being listed as an alternate destination for non-941. So not mental hygiene law, but just somebody who needs someone to talk to and needs some mental health assistance, whether it's they're out of their everyday medication or they want to establish because they just moved here and they're feeling depressed, but they have no thoughts of suicide or no attempts in the past as an acceptable alternate destination. I wish Dr. Lynch were able to be here today because he is the sort of physician liaison with that group that has been advocating for this. They were issued an interim approval to facilitate, their application to the state. I don't have an update from the state about that because the state doesn't answer to me. But I know we expressed, basically the interim approval is a willingness to entertain this in the region. And so that was provided during in between the last meeting and this one. I haven't heard anything from them regarding their application.
Dr. O'Brien?
Yes, sir.
So we got clarification from the state yesterday at a meeting about this.
Great.
I am 100% supportive of this site as an alternate destination. I'm glad the REMAC has supported this. This is not yet ready for prime time though. So even though we've supported it and even though there's alternate with other places, until the state guidance comes out regarding models of who goes to these locations, they are not live. So I just wanted to make sure that that was unambiguous.
I appreciate you bringing that up. I probably should have just put this under chairman's report because it's really just I'm telling you that this has happened and it's in the works. But it is something that's on the horizon. It's something that I'm looking forward to as a possible way to ease some of the burden on the local emergency and urgent healthcare system. But just for the information and edification of the committee. I have the letter from Best Self. I will read it aloud. It is not terribly long and I speak kind of fast. But here's what it says. It is, excuse me, it is from the president and CEO of Best Self Behavioral Health. So this was their proposal letter. Dear REMAC and New York State DOH leadership, on behalf of Best Self Behavioral Health, I am writing to request recognition of our Intensive Crisis Stabilization Center located at 430 Niagara Street in Buffalo, New York, as an approved alternate destination, EMS destination under New York State EMS guidelines. The ICSC will operate 24 hours a day, 7 days a week, 365 days a year, serving both adults and youth who are experiencing behavioral health or substance use crises. The program is designed to provide a safe, person-centered alternative to emergency departments for individuals in crisis who are medically stable and appropriate for a crisis stabilization setting. Patients who require acute medical stabilization, involuntary psychiatric admissions, or emergency medical interventions beyond the scope of crisis stabilization services will not be admitted to the ICSC and will continue to be transported to hospital emergency departments. In practice, appropriate patients for ICSC transport include those experiencing suicidal ideation, not on papers, or severe emotional distress without acute medical instability, individuals demonstrating psychiatric symptoms such as anxiety, depression, psychosis, or agitation who remain medically stable, and those experiencing substance use related crises that can be safely managed in an ambulatory setting. This includes individuals who have received naloxone for an opioid overdose and are stable for further evaluation and support. Conversely, patients who are not appropriate for ICSC transport include individuals presenting with chest pain, stroke symptoms. I don't know why we would bring them there. Seizures, traumatic injuries, or unstable vital signs. Patients experiencing severe respiratory distress, acute alcohol withdrawal with seizure risk, children under the age of 12, or individuals requiring involuntary admission or hospital level interventions should continue to be transported directly to an emergency department. Okay. The rest of this is details on how it'll work, which we'll just disseminate if and when it's approved for regional use. But that's an example of what the intent is. I think that their breadth of services is impressive, and they may in fact be able to take some of the burden off of the departments, which I think is a win for everybody. So I look forward to hearing more as the state and Best Self sort of work out what that will look like. And then we will make sure we notify the committee and all of the regional agencies through STEMS and UVMD, if and when that is ready for prime time use with sufficient details on a go live date, but B, any specific operational requirements and assessments and things like that will be needed in order to identify patients that are appropriate for that place or identify the patients that really need emergency department evaluation. All right. Any other questions or comments on that? Okay. We have probably a record low number of various approvals. So that concludes new business really except for this. So we have a PAD notification for Champion International. We have two superglide airway applications for Alcott Fire Department, as well as Crandall Hook and Ladder. I'm gonna separate the Alcott, is it Alcott? Yeah, I'm gonna separate Alcott into a separate vote. But I would like to entertain a motion to approve AE Crandall's Hook and Ladder superglide airway application, because we did receive their letter of intent, their application, and their training details, as well as the Chapin International pad notification for approval. I guess it's FNS.
Can I raise a question about robotics for a second?
Sure.
Before we vote. So I think the state policy, whatever that is, 2509.
Yeah, right here.
2509, says that the REMAC has to approve training programs for agencies implementing superglottic devices. Which I think is part of the application process, and then it goes to the division. You guys can correct me if I'm wrong, for final approval. So I think one of the things that we are required to do is specifically to look at what we are approving as training practices. So that said, I have a couple of suggestions with that. One is, and I think if you look at AE Crandall, right, which is Dr. Farney's agency, they are using a training program that Milrems has put together and has a policy statement on, which I think covers all the required aspects of training, and I think that we would all, I would personally, and I think most people would say is sufficient. I guess the other question then is for other agencies in the future, because I don't know that we as a REMAC want to go individually through every agency who applies for this, through what their training process is and how they're doing it. I would suggest that we maybe look at some of the things that are out there that we would say, this meets our standard if you are using this for training. Such as when this was a pilot program, the required training for the pilot program that was on Vital Signs Academy is still available on Vital Signs Academy and is listed in the that state policy statement 2509 at the bottom is one aspect. And the other part of that is then capnography from the BLS provider, which was originally developed on Milrems and actually given to the state and is now put on Vital Signs Academy as well and available to anyone. I would suggest that the training that we would require would be both of those didactic portions that you can do online, and then obviously specific training with the superglottic device and your end-tidal CO2 in your agency. As opposed, so I guess what I'm saying is I think if those things are out there, maybe we want to endorse those as a REMAC, rather than looking individually through every agency that applies and what their own homegrown training program is. Maybe we should try to specify if you follow these things available on Vital Signs Academy, or you follow Milrems, which is essentially the same thing, but they will separate policy on it. Maybe those we would keep as acceptable and not have to reinvent the wheel or look through all the training programs every time someone applies.
Thoughts? None? I don't see a reason why, well, I think anybody who's, I think it'd be reasonable to say anybody who's using those two didactics and has some sort of hands-on in their agency, under the purview of their medical director, could get, sort of I would feel comfortable issuing interim approvals for them to support their applications to the state. I don't know that I want to demand that in order to get the REMAC support, they have to do those things. I think in cases where their application does not include those things, that would require review. And to make sure that they're, substantially similar and meeting all of the goals and objectives of the didactics that are online. Because I don't want to hamstring an agency that maybe doesn't like how it's presented and wants to do the same material their own way. But I also think a lot of agencies will be happy to use what's already available.
And I guess maybe I agree with what you're saying. Maybe I should rephrase that and say that if they're using one of those trainings that, we endorse it and bless that. If they are using their own homegrown, they can still do it, but that will take a little bit more review, I guess, and approval is what I'm thinking.
Yeah. I mean, I'm happy to do that on behalf of the REMAC if you're comfortable with it. To review it and when we talk about the vote and bring it up and say this is one of the agencies that has their own, I've reviewed it, it meets or exceeds the state's goals and objectives on the 2 online didactic sessions. And then we would have that, or if you want, we can send it out to the entire committee and then everybody can make their own assessment of that before we vote. I'm fine doing either one. But I agree with the idea of generally, let's recommend what's already available and not reinvent the wheel for agencies that don't want to or don't have the resources to do that.
Yeah, or maybe it's just a understanding that if you use one of these trainings that's already out there, we will approve it.
Yeah, I'm fine
Do
with
your
that.
own, review it to make sure.
Yeah.
Spirit of that.
I like that. That makes sense. Other thoughts? Maybe have concerns with that approach?
I would think most agencies would probably want to use what's already out there and
Agreed.
meets the requirements.
Okay. That was why I parsed out Alcott. I agree with that. I don't know that that needs a vote. I guess it probably does, but. No, I don't think it does.
Maybe just a discussion point for
Yeah.
future applications and
Yeah.
that, so.
That'll be the process we use, right? Any agency that applies. And their training includes both of the online didactic modules and some type of hands-on training is approved by their medical directors. Can expect to receive approval by the REMAC. Anybody that submits their own training, we will review it, and if it meets or exceeds those things, you can also expect it, but after a review. So being that AE Crandall Hook and Ladder uses the 2 online didactics. And I certainly know that Dr. Farley is involved in his agencies and will make sure that their skills are appropriate. I'm happy to include them in the vote along with Chapin wanting to shock people.
Give a motion.
Yes.
I will make a motion.
Is there a second?
Kenyon,
And now there's a second. Is there discussion? Was that somebody on the phone seconding?
I think it was kind
Oh, thank you. Okay. Any opposition to approving AE Crandall and Chapin International? Hearing none, the motion carries and they are both approved. Alcott Fire did not include their training with their application. So I will reach out I will ask Karen to kindly reach out to them on our behalf. And if they submit with our new interpretation or decision, if their training materials include the 2 didactics, I will issue them an interim approval based on our expedited review we just agreed to. If they do not, then I will review it and I will be prepared to discuss that at our next meeting for a formal consideration. Any other new business before the committee? Hearing
Hey,
none,
it's Aaron
time
Farney.
to-
Sorry,
What?
quick question that came up, Aaron Farney here. Looking at the Western REMAC website, there appears to be 2 policies that are perhaps redundant. This isn't something we have to solve today, but I just want to put it on the radar maybe for next meeting. 2004-4 and 2017-2. My interpretation is they appear to be both addressing the same topic of downgrading care for transport. But if we can just take a look at that in the interim and then maybe revisit it at the next meeting.
Yeah, absolutely. So 2004-4 and 2017- what? I'm sorry, Aaron. 2? Okay. Yep.
Yes, thanks.
We'll put those on the agenda for new business for next time, so we can try to reconcile those, because I agree there's a lot of overlap.
And that may be something that was when we developed updated the transfer care policy with 2017 policy, maybe it just didn't get rescinded or taken off the website.
It could be. I mean, this was the intent of the policy review committee was to catch things like this, but they've had limited meetings, and then Dr. Plunkett became a mother, got busy with life. But I know it's on their list, but I think we should address that one next meeting. All right. There being no further new business, it's time for someone to move to adjourn. All right, is there a second? Okay. I'm not asking everybody, we're done. Thank you all for being here. We'll see you next time.